Continuing the Reed Harrison series, and in this class we will be talking about diabetes mellitus, primarily focusing on clinical features and also the current recommendations with respect to screening. In the previous class we have learned about the types of diabetes mellitus and the diagnostic criteria, and as usual, as I have already promised before we started with the Reed Harrison series, that we will go through the MCQs so that you are prepared for NEET PG as well as your final prof exam. And hopefully, as we go on integrating clinical cases, you should be prepared to face the patients as well. Okay. Now, before we start with the today's discussion, a small correction on the previous lesson. So in the previous lesson, some of you had sent me texts asking, sir, how do we achieve the depolarization of the beta cells with rising glucose? One of the correction that I want to emphasize is that we achieve the depolarization by blocking the potassium sensitive ATP channels and not by opening, as I said in the previous video. So please let us correct that. Okay, so now let's begin with the understanding of the clinical features and the screening recommendations for diabetes mellitus. Good evening, everyone. Good evening, everyone. Okay, but before that, some of the important MCQs or PYQs based on the previous class, that is types of diabetes mellitus. So here is the first question. In this question, we have a 11-year-old. Please look at the age of the person. It is 11-year-old was brought with frequent urination. That is, frequent urination means polyuria, as we know, right? Patient was brought with polyuria and unusual thirst. Whenever they say unusual thirst, it is pointing towards polydipsia. So this patient has got polyuria and polydipsia. And at presentation, his blood glucose level RBS done at presentation, it is RBS, which was 240 milligrams per deciliter. C-peptide levels were undetectable. C-peptide levels were undetectable. Which of the following statements about this child's condition is true? So I have first question. Is this patient having diabetes or not? Can I diagnose the diabetes based on the criteria that we have discussed in the previous class? What were the criteria for the diagnosis of diabetes mellitus? Fasting blood glucose values more than or equal to 126 milligrams per deciliter, or 2-hour postprandial blood glucose value, which is standardized with the 70 grams of anhydrous glucose, oral glucose tolerance, if that is more than or equal to 200 milligrams per deciliter, or HbA1c is more than or equal to 6.5%. And we learned about a fourth condition. What was the fourth condition? We can diagnose the diabetes with RBS more than or equal to 200 milligrams per deciliter, provided patient is having symptoms of diabetes. What are the main symptoms? Polyuria, polydipsia, polyphagia, and weight loss. So this patient is having the symptoms and RBS is 240 milligrams per deciliter. So I can make the diagnosis of diabetes according to the criteria that we learned in the previous class. So this patient is having diagnosis of diabetes for sure. Now I have to decide which type of diabetes it is to answer this question, because the options are may not require insulin for at least 6 months after the diagnosis. Where do we talk about this patient not requiring insulin for 6 months after the diagnosis? It was part of the diagnostic criteria for an entity called as LADA, latent autoimmune diabetes of adults. Okay, then family history of DM in at least 3 successive generations. Where did we talk about family history of diabetes in 3 successive generations? If 3 successive generations are involved, of course, there is an inheritance pattern. It has to be autosomal dominant. And the autosomal dominant form is going to be which one? Maturity onset diabetes in young, MODY, right? Then insulin resistance is the hallmark feature of pathogenesis. Where is the insulin resistance involved? Type 2, as we know, right? And then third, may be positive for anti-GAD antibodies, which is seen in type 1A diabetes, autoimmune type 1 diabetes. So which type of diabetes this patient is likely to be having? Diabetes is there based on the criteria we have decided. Now which type it is? Is it type 1, type 2, LADA, MODY? What do you think? Which type it is? Okay, now please remember here, there is one important point mentioned in this question. The C-peptide levels are undetectable, means insulin production is low or absent. So where do we get that? Of course, type 1 diabetes mellitus. So that means this patient's diabetes is because of the lack of insulin and not because of insulin resistance. So we are dealing with type 1 diabetes mellitus. So now what will be the right answer? Okay, so let me quickly run a poll and see how many of you can give me the right answer. So we'll do these quizzes in all the upcoming classes so that we are prepared for the NEET PG or MCQ based exams as well. Anand Hospital, very good. Suraj Day, very good. So a lot of such MCQs are being asked where you have to decide which type of diabetes mellitus it is, and it's very important because once we see someone's reports, we know that this patient is having diabetes. We also need to decide whether it is type 1, type 2, MODY or LADA, because management differs, right? Management is not blanket. Okay, awesome. So all of you gave the right answer. Very good, very good. Now let's go to the next question. Okay, so here is the next question. Which of the following qualifies for the diagnosis of diabetes mellitus according to current ADA criteria, American Diabetes Association criteria? Current criteria is 2025 criteria. Anyway, it has not changed over last few years. FBS 210 milligrams per deciliter, RBS 160 milligrams with polyuria, RBS 210 milligrams per deciliter and HbA1c of 6.2%, and FBS 138 milligrams per deciliter and HbA1c 6%. So multiple answers may be correct. So can you tell me what all qualifies to be called as diabetes mellitus? Okay, is option A diabetes mellitus? Is option A diabetes mellitus? Does it satisfy the criteria for DM? So what was the FBS criteria? FBS criteria was FBS more than or equal to 126 milligrams per deciliter. So does that satisfy? And again, please remember, any one, whatever criteria we listed in the previous class, any one criteria met, it is diabetes mellitus. We don't have to meet all the criteria. So first criteria definitely satisfies the criteria for diagnosis of diabetes mellitus. So it is one of the correct answers. Okay. Second one, does it satisfy RBS 160 with polyuria? When RBS can be used for diagnosis of diabetes, when patient is symptomatic of diabetes and RBS value is more than or equal to 200 milligrams per deciliter. Here it is not more than or equal to 200, it is less. So this does not satisfy the criteria. Okay, the next one, C. RBS of 210 milligrams per deciliter and HbA1c of 6.2%. Does it satisfy the criteria? Now please remember, HbA1c does not satisfy. HbA1c has to be 6.5% or more. Does RBS satisfy? RBS can be used as a criteria only in presence of symptoms, right? Without polyuria, polyphagia, polydipsia or weight loss, you cannot diagnose the diabetes just based on the RBS. So random blood glucose level alone cannot be used for the diagnosis of diabetes in asymptomatic individuals. So this does not satisfy. Neither HbA1c satisfies nor RBS satisfies, right? So if you are using RBS has to be 200 plus with symptoms, right? Please go back to the previous lesson where we have discussed this in clarity. Last one, FBS 138 milligrams per deciliter and HbA1c of 6%. Does it satisfy the criteria for diagnosis of diabetes? HbA1c does not, but what about FBS? FBS has to be more than or equal to 126 milligrams per deciliter. So it definitely satisfies. So these two are option A and option D. These are diabetics. These two cannot be called as diabetics with the available information, right? Okay, let's go through one more question before we discuss the clinical features. Which of the following characterizes stage 1 of type 1 diabetes mellitus? So in the previous lesson, we learned about 3 stages of diabetes mellitus: stage 1, stage 2 and stage 3, right? So first option is elevated fasting blood glucose with symptoms of polyuria and weight loss. Symptoms of polyuria and weight loss. Presence of islet autoantibodies with normal blood glucose levels and no symptoms. Option C is hyperglycemia with impaired insulin secretion and overt symptoms. Option D is absence of autoantibodies and normal glucose tolerance. So which can be considered as stage 1 of type 1 diabetes mellitus. Stage 1 of type 1 diabetes mellitus. Aniket, you have any doubts in the question? Okay, I'll go back to the question after this poll. What qualifies for the stage 1 of type 1 diabetes mellitus? Okay, again, good. Most of you got the answer right. So what was stage 1? Basically, type 1 diabetes mellitus is majoritarily caused by autoimmune response, and there has to be a trigger which triggers the autoimmune system and body start producing antibodies. In stage 1, we just have antibody production, and these antibodies are causing the damage to beta cells, but beta cell mass is not critically decreased. Patient will not have overt hyperglycemia and symptoms of diabetes. Only antibodies will be positive. In stage 2, beta cell mass has further come down. Now, impaired glucose tolerance, impaired fasting glucose, or pre-diabetes stage can be encountered there. Basically, dysglycemia and overt, obvious hyperglycemia and clinical features will become evident in stage 3. So, the best description of stage 1 will be presence of antibodies, but still normal blood glucose and no symptoms. Okay, so in question 2, why option C is not diabetes according to ADA criteria? So, what ADA says, there is an FBS criteria, there is a 2-hour postprandial glucose criteria, HbA1c criteria, and RBS criteria. 4 criteria are there. Any one of them satisfied, we can call it as diabetes. So what is the FBS criteria? FBS criteria is your fasting blood glucose should be more than or equal to 126 milligrams per deciliter. The first option satisfies that, that's why it is diabetes. Then second one is postprandial glucose. After taking 75 grams of anhydrous glucose, it has to be 200 or more than 200. Anyway, none of the questions are talking about postprandial glucose. The third one is HbA1c. HbA1c has to be 6.5% or higher. The fourth one is RBS. RBS, randomly taken blood glucose level of more than or equal to 200 milligrams per deciliter, can be used for diagnosis of diabetes only in presence of symptoms of diabetes. Without the presence of symptoms of diabetes, RBS cannot be used for the diagnosis of diabetes. It can raise the suspicion. You can establish the diagnosis by doing HbA1c or FBS, PPBS, but RBS alone in the absence of symptoms cannot be used for diagnosis. So our option C mentions RBS more than 200, but it is not talking about the presence of symptoms. While option B was talking about presence of symptoms, but the value was not sufficient. In C, value is sufficient, but it is not talking about the presence of symptoms. And neither HbA1c is more than 6.5. So I can call this patient as pre-diabetic, but not diabetic. I'm calling him as pre-diabetic because HbA1c is more than 5.7, but less than 6.5. But here, HbA1c criteria does not satisfy, but the FBS criteria satisfy. That's why option D is the answer. Okay. So now today let us discuss about the clinical features of diabetes mellitus. Okay. But before we learn about the clinical features of diabetes mellitus, okay, there are some epidemiological points that we need to know. The first thing I want you to know is that when we talk about type 1 diabetes mellitus, 70 to 90% patients of type 1 diabetes mellitus are symptomatic at the time of presentation. So they generally come to hospital because they develop the symptoms. On the other hand, when we talk about type 2 diabetes mellitus, right, 50 to 90% of the patients of type 2 diabetes mellitus are asymptomatic at the presentation. So because they get diagnosed as diabetic because of routine screening and not because they have developed the symptoms. So 10 to 15% may be symptomatic at the time of presentation, and out of that 5 to 10% may have complications of diabetes. So by the time they recognize, they already have developed the complications of diabetes mellitus. So now tell me, diagnosing which patient is going to be more difficult for us? Which patient is going to be more difficult for us? Is it type 1 or is it type 2? Yes, diagnosing the type 2 patients is going to be more difficult because they don't generally develop the symptoms, right? So we have to screen them and identify, because I don't want to see any of my diabetes patient presenting at this stage, right? I don't want them to come to me when already complications have happened, because diabetic complications, once they happen, they cannot be completely reversed. On the other hand, these patients generally present as soon as they start noticing the symptoms, right? So for these patients, screening is very, very important. Now, when do I start screening? Now, all of us know that if you are born and you are alive, as you age, you definitely have some degree of risk of developing diabetes mellitus. Right? Anand Hospital, Aniket, Tiga, yes, all of you are right. So diagnosing type 2 diabetes is more challenging. Until and unless we screen, we may not recognize these patients, right? If I fail to recognize in the asymptomatic stage, then I will either diagnose them quite late when they become symptomatic, or I will diagnose them when they have already developed the complications of diabetes. So when should I start screening? Now, one of you tell me, right now my age is 43 years. So at this age, should I be screening myself for diabetes or not? At 43 years of age, should I be going through diabetes screening or not? Like, should I get my sugars tested? Yes. So what age we should start the screening for diabetes mellitus? This was an MCQ asked in INI-CET as well. At what age we should start the screening for diabetes mellitus? So when it comes to diabetes, we generally follow the American Diabetes Association guidelines and the ADA guidelines for 2025, and even most of the recent ADA guidelines 2024, 2023. What do they recommend? In adults aged more than or equal to 35 years of age should be screened for diabetes. So now I'm 43, so I should have started screening for diabetes when I turned 35 itself. Okay. Now, should I start screening early in some selected individuals? Because nowadays you hear the news that people got diagnosed with diabetes when they were 28, 27, 25. So when should I start screening early? So for adults aged less than 35 years, with overweight or obesity, overweight or obesity, early screening is recommended. Overweight with or obesity. Again, when I say overweight or obesity, so please remember, when should I consider them for screening? If it is Asians, BMI for the rest of the world, BMI more than or equal to 25, and for Asians, BMI of more than or equal to 23. More than or equal to 23. For rest of the world's BMI more than or equal to 25, but for Asians including Indians, once our BMI is more than or equal to 23, we should start screening those patients for diabetes even before 35 years of age. So one of you may say, sir, I am just 24 years old and my BMI is 26. Should I go for the screening of diabetes? Absolutely yes. You need to be screened for diabetes, provided you have an additional risk factor. What are those additional risk factors? If you have a first degree relative with diabetes, or you have also coexisting hypertension, or your HDL level is low, HDL level less than 35 milligrams per deciliter, less than 35 milligrams per deciliter, or your triglyceride levels are high. How much high? The triglyceride levels more than 250 milligrams, more than 250 milligrams per deciliter, or you have PCOS, or you have the evidence of insulin resistance in the form of acanthosis nigricans. So let me summarize again. Adults aged more than or equal to 35 years, everyone should start screening for the diabetes. We can consider early screening for diabetes before 35 years of age if the individual is overweight or obese and has an additional risk factor. So when do I count them fitting into this category? If we are talking about Asians, when their BMI is more than or equal to 23, with an additional risk factor like one of the family member or first degree relative having diabetes, PCOD, hypertension, low high HDL or high triglyceride levels, or acanthosis nigricans. In these cases, we need to start screening. Now comes the question, what if, sir, I got the screening done and the values are normal. So when should I screen myself next? After 1 year, 2 year, 3 years, 6 months, 5 years. So if screening is negative, right? If negative, if screening is negative or values fall in normal range, repeat every 3 years. So I should have screened myself at 35 years of age. If that was negative, at 38 again, at 41 again, at 44 again. So every 3 years, I need to keep repeating. And anytime I get detected as diabetic, then of course I am diabetic and the rest of the management will follow accordingly. If not diabetic, I will continue maintaining the lifestyle, right? So now we have a fair idea when to start screening. MCQs are expected on this topic, so please remember this. Okay. So now these 70 to 90% of type 1 and few type 2 diabetic patients, they may present with symptoms. So what symptoms they are bringing to the hospital? What are the common clinical features of diabetes mellitus? These are also called as cardinal manifestations of diabetes mellitus. Cardinal manifestations of diabetes mellitus. So what are these cardinal manifestations? The first and the most important one is polyuria. Polyuria, increased urination. Second, polydipsia. Polydipsia or increased thirst. Third, polyphagia or increased hunger. That's why we call it as 3Ps of diabetes mellitus. And now in the recent times, one important cardinal manifestation got added to these 3Ps, and that is the weight loss. Weight loss. So these are the 4 cardinal manifestations of diabetes mellitus. These are the symptoms that usually type 1 diabetes present. Type 2 mostly get recognized because doctors screen for it. Okay. Now, can anybody explain why are we going to get polyuria in patients with diabetes? Why should I pee more if I have diabetes? What is the mechanism? Bharat Seva Reddy, we are planning to cover the entire spectrum of topics in Harrison. Of course, it will take time and we are going with reasonable detail so that it's not a superficial revision but rather sufficient for final prof, NEET, PG and clinical practice as well. Okay. So why do we get polyuria in diabetes mellitus? Okay. So important point is glucose is an osmotically active substance. In fact, what are the 3 most important osmotically substances in the body? Okay, forget about glucose. What is the most important osmotically active substance in the body? Ankit ticks very good. Okay, sodium is the most important osmotically active substance in the body. After sodium, it is glucose and urea. These are the 3 most important osmotically active substances in the body. So whatever we have as blood osmolality, it is mainly because of sodium, glucose and urea. In fact, there is a formula for calculation of the serum osmolality. What is the formula? For the formula, we multiply sodium values with 2 and then glucose values divided by 18 and blood urea nitrogen divided by 2.8. So these are the 3 major: sodium, glucose and blood urea nitrogen. These are the 3 most important osmotic substances in the blood. So if blood glucose level increases, what happens to serum osmolality? What happens to serum osmolality? Of course, the serum osmolality will increase. Now, if I want to get the serum osmolality back to normal, what should I do? If the serum osmolality is increasing because of increasing blood glucose level, but body wants to keep the serum osmolality back to normal. What is the normal serum osmolality? Normal serum osmolality ranges from 280 to 290 milliosmoles per liter. 280 to 290 milliosmoles per liter. So there are 2 things I can do. See, first thing is, if glucose value is increasing but I want to keep the serum osmolality normalized, then I can decrease the sodium. So I can shift this sodium from extracellular compartment or from serum to the intracellular compartment so that the serum osmolality gets kind of normalized. So can hyperglycemia or a diabetes lead to hyponatremia? Theoretically, yes. We will call this kind of hyponatremia as pseudo hyponatremia because total body sodium is not actually reduced. The sodium has just exited the plasma and gone into the cells. Second thing, best thing what I can do is, instead of trying to shift the sodium to intercellular compartment, I can get the glucose itself down. But to get the glucose down, I need insulin. I have either insulin deficiency or insulin inaction, type 1 versus type 2. In that case, what I can do? I can eliminate more glucose in the urine, right? So now, as the blood glucose level starts increasing, urinary excretion of glucose also starts increasing. So if urinary excretion of glucose starts increasing, how will that cause polyuria? How will that cause polyuria? Yes, it is linked, but how? Because as we just learned, glucose is an osmotically active substance. So when I excrete glucose in urine, glucose alone will not go. It will take water molecules along with it because it is an osmotically active substance. So now I am excreting glucose. Along with that, I am excreting increased amount of water. That's why I will end up with polyuria. So when I end up with polyuria, I am not only losing glucose, but I am losing water. So what will happen to the total body water content? The total body water content starts coming down. So how will I get it normalized? As the body water content starts coming down, the serum osmolality will rise and it will activate the thirst center. That's what happens, right? You don't drink water for a long time and you become thirsty. So if my body water starts depleting, I'll become thirsty. So my thirst center gets activated and I start drinking more water and I will end up with polydipsia. So these two P's, polyuria, polydipsia, are linked. Glucose loss in urine results in water loss. Water loss results in activation of thirst center and that results in polydipsia. Now why polyphagia? Polyphagia means increased eating or increased hunger. Why do they have polyphagia? In the first class only I've told you that insulin is not only about, its function is not only about regulating the blood glucose values in the normal range. Insulin is required for the utilization of the glucose by the cells. So in the absence of insulin or in the absence of insulin's action, tissues or cells may not be able to utilize the glucose. And when they're not able to utilize the glucose, even when your blood glucose level is high, tissues are still hungry for glucose, right? So hunger mechanisms get activated, trying to get more glucose delivered to the tissues. And that's why these patients start eating more and end up with polyphagia. Okay. And when glucose level suddenly increases at high glucose levels, it activates catabolic processes and patients can start losing the weight. So these are the four cardinal manifestations. One MCQ that I'm anticipating on this is, which of the following is recently added to the list of cardinal manifestations, and that is weight loss. Okay, so that's the mechanism for polyuria, polydipsia, polyphagia. Now, apart from these symptoms, am I worried about diabetes because someone develops polyuria, polyphagia, polydipsia? See, polyuria, it's a problem because patient need to use the restroom quite frequently, but it's not a life-threatening problem, right? Polydipsia, is that a problem? As long as we are in India and we're not dependent on some other country to give us water, our thirst can be quenched by water, whatever water supply we have. So the more I lose in the urine, more I drink, my hydration is balanced and it should not be a life-threatening condition, except extreme hyperglycemia, too much of polyuria, severe dehydration as in case of DKA, or hyperglycemic hyperosmolar state. Otherwise, these are not going to be life-threatening directly, at least in the mild cases. Then why should I be worried about diabetes? Well, diabetes not only causes these four cardinal manifestations, it also leads to complications. So what complications diabetes can lead to? Well, when there is long-standing hyperglycemia, that excess glucose activates certain processes. One of them is through polyol pathway. So there is a pathway that you study in biochemistry called as polyol pathway. This glucose gets converted to sorbitol, which is a sugar alcohol. And this sorbitol activates, or it increases the oxidative stress. Oxidative stress. So there's oxidative damage to tissues. So it's not only about polyuria, polyphagia, polydipsia and weight loss, but also tissues are experiencing increased amount of oxidative stress. Okay. Second, this excess glucose leads to activation of diacyl glycerol and protein kinase C pathway, and activation of this pathway results in increased expression of endothelin 1. What endothelin 1 does? Endothelin 1 causes vasoconstriction. It causes vasoconstriction. It causes vasoconstriction. And blood vessels are now constricted, so tissues are not only experiencing oxidative stress, tissues are getting less blood supply because of this vasoconstriction. Okay. Other thing that activation of the diacylglycerol the protein kinase C pathway does is there is thickening of basement membranes of the cells. So tissues characteristics are now getting altered. Okay. There's one more thing that this long-standing hyperglycemia or excess glucose does. Now, when blood glucose level increases, insulin comes, and what it does? It tries to shift that blood glucose into the tissues, and what it stimulates the tissues to do? Use the glucose, or if you are not able to use, you don't need to use it, then save it in the form of glycogen and fat, right? But when fat storage and glycogen storage organs become saturated, where else I will put those glucose molecules? Those glucose molecules start getting attached to protein molecules. This is what we call as glycation and glycosylation. So in fact, glucose is a reducing substance. Glucose reacts with the amino acids in proteins to form a product called as AMDORI products, AMDORI, AMDORI products. And those products alter the structure of the protein, and that altered protein we call it as advanced glycation end products. We call them as advanced glycation end products. One such example is HbA1c. What is it? It is glycosylated hemoglobin. So hemoglobin is not the only protein to which the glucose molecules are getting attached. Multiple tissue proteins become glycosylated. And once they are glycosylated, we call those as advanced glycation end products. Now these advanced glycation end products interact with something called as RAGE. RAGE stands for receptors for advanced glycation end products. So for this AGE, there are receptors on the cells. They interact with them, and once they activate these receptors, the activation of these receptors results in increased expression of a nuclear factor pathway called as NFK beta. NFK beta pathway becomes activated. Now, what this activation of NFK beta will lead to? It leads to two things. It leads to increased production of inflammatory cytokines like interleukin 1, interleukin 6, which are all inflammatory cytokines. So now my tissues are going through oxidative stress. They are getting less blood supply. Now they are also going through bear the brunt of inflammation because of these inflammatory cytokines. The problem doesn't end there. This activation of NFK beta pathway also leads to increased expression of growth factors. So what these growth factors will do? Growth factors function is to stimulate the proliferation of cells in the tissue. So cells are now being stimulated to proliferate or replicate more, that too in presence of inflammation, in presence of oxidative stress and reduced blood supply. So tissues will become more and more dysfunctional. They are growing, the cells are growing rapidly. That's why we say, when we talk about diabetic retinopathy, we have the stage called as proliferative diabetic retinopathy. Why that proliferation is happening? Because of increased expression of growth factors. I will list some of the important growth factors and we'll talk a little bit about their mechanisms. So one of them is vascular endothelium derived growth factor. Endothelium derived growth factor or VEGF, right? Increased expression of VEGF is implicated in the pathogenesis of diabetic retinopathy. And VEGF blockers are used for the treatment of diabetic retinopathy, right? Similarly, there is a transforming growth factor beta. Transforming growth factor beta. This transforming growth factor beta stimulates fibroblasts and makes increased deposition of extracellular matrix around various tissues, including the kidneys and the retina, everywhere. There is also increased production of platelet derived growth factor. So now this leads to tissue proliferation. There is tissue inflammation, tissue oxidative damage, and reduced blood supply to tissues. Okay. Apart from that, glucose itself is an oxidative substance. So glucose can also directly lead to oxidative stress. So excess or long-standing hyperglycemia results in oxidative stress, blood vessel vasoconstriction, thickening of the basement membranes, inflammation of the tissues, and proliferation of the tissue cells, particularly proliferation of the endothelial cells. Proliferation of the endothelial cells results in, like, as the endothelial cells proliferate, especially smaller blood vessels, there is narrowing of the lumen. Plus, long-standing hyperglycemia is also a risk factor for accelerated atherosclerosis. Accelerated atherosclerosis. So patients with diabetes have faster development of atherosclerosis than patients without diabetes. So these are all the mechanisms involved in generation of complications of diabetes. But what complications we're expecting? Two things are happening here. One, damage to tissues, because these growth factors are causing tissue proliferation and inflammation, which results in scarring or fibrosis. Second, tissues are now getting depleted of blood supply. Third, tissues are going through oxidative stress. Which tissues bear the brunt of the diabetes? Almost every tissue from top to bottom bears the brunt of this diabetes, and complications can happen to any tissues. We will list the important ones. Traditionally, we classify the complications of diabetes into two groups: microvascular, where smaller blood vessels are involved, and macrovascular, where larger blood vessels are involved. The mechanism behind the macrovascular complications is accelerated atherosclerosis and this formation of advanced glycation end products. The mechanism behind microvascular is oxidative stress, activation of DAG-PKC pathway, and advanced glycation end products. Okay. So what are the major macrovascular complications? The first one is there is increased risk of ischemic heart disease, or you can also call it as coronary artery disease. Second one is there is increased risk of cerebrovascular accidents or stroke, cerebrovascular disease or stroke. So having diabetes increases your risk of developing coronary artery disease by 3 to 15 fold, and having the diabetes increases your risk of developing the stroke by up to 6 fold. In fact, for the stroke, diabetes is considered as the strongest risk factor. That's an MCQ that you need to remember. Diabetes is the strongest risk factor for development of stroke. And if you go back to the stroke, there you come across something called as TIA, and TIA, the risk of developing stroke, we have this ABCD2 score, and one of that component is presence of diabetes. Okay. The third one, peripheral vascular disease. So basically large blood vessels getting occluded because of long-standing diabetes, peripheral vascular disease. In fact, world over right now, diabetes and smoking are the two leading causes for amputation of the limbs because of blood vessel blocks. So when someone's legs got amputated, the leading causes are uncontrolled diabetes and smoking. So these are the macrovascular complications. We also have microvascular complications. There's a very easy way to remember the microvascular complications. All you have to remember is pathies. So this, all the mechanism that we discussed just now, this oxidative stress, vasoconstriction, thickening of basement membrane, inflammatory cytokines, and these growth factors, they cause damage to the kidneys and nerves. So when the kidneys get damaged, we call it as diabetic nephropathy. Diabetic nephropathy. Now this diabetic nephropathy results in, it starts with proteinuria. Patients start losing protein in the urine or albuminuria. From proteinuria, eventually they progress to chronic kidney disease or chronic renal failure. In fact, diabetes mellitus is the most common cause for CKD worldwide as well as India. The leading cause for CKD, leading cause for someone requiring dialysis is diabetes mellitus. It begins with microalbuminuria, eventually progress to the GFR loss, and then patient has CKD and all complications. Second, diabetes also causes damage to the nerves. We will call it as diabetic neuropathy. Diabetic neuropathy. What is the mechanism behind the damage to nerves? Same, the previous, all these mechanisms. Sorbitol is involved, oxidative stress, blood vessel involvement, inflammation, growth factors, all of them are involved causing the damage to the nerves as well. We will call it as diabetic neuropathy. Now, when I talk about neuropathy, which nerves are being affected? Is it peripheral nerves? Is it the autonomic nervous system? Please remember, it affects both. So when we talk about diabetic neuropathy, it can affect peripheral nerves as well as autonomic. So it causes autonomic neuropathy and peripheral neuropathy. And peripheral neuropathy. And when it is causing peripheral neuropathy, it can affect a single nerve, it can affect multiple nerves, so it can cause mononeuropathy as well as polyneuropathy. So one thing that I want you to remember is that what is the most common form of peripheral neuropathy caused by diabetes? The most common form of peripheral neuropathy caused by diabetes is polyneuropathy. Now, when it is polyneuropathy, which part of the body it is affecting? Yes, it is causing distal. It affects both sensory as well as motor. So it causes distal sensory motor neuropathy. Sensory motor neuropathy. We will discuss more about the diabetic neuropathy. It's going to be a separate session about these complications, where the stages of the diabetic nephropathy, different types of neuropathy, how to differentiate between small fiber, large fiber, we will discuss later. For now, we will have an overview of three complications. The most common manifestation of peripheral nerve involvement is distal sensory motor neuropathy. So what does that mean? Patients will have the damage to the nerves going to the distal parts of the body, right? Absolutely right. We call it as glove and stocking distribution. Generally speaking, polyneuropathies are most commonly distal. They are affecting distal parts. And what are the distal parts in the body? The hands, right? Forearms, feet, and the legs. So when they get affected, it's the same area where we wear the gloves and the stockings. So that's why this is also called as glove and stocking distribution of neuropathy. Okay. Now, autonomic neuropathy means autonomic nerves are also being targeted by the advanced glycation end products, then polyol pathway, oxidative stress. So when autonomic neurons get affected, what manifestations I can expect? What manifestations I can expect? What is the main function of the autonomic nervous system? One of them is it regulates heart rate. It regulates your respiratory functions. Does it regulate the blood pressure? Of course, it also regulates the blood pressure. Yes, diabetic foot is a manifestation of two factors. One, the direct complications of diabetes plus neuropathy. Right? We'll discuss more about it as we take the diabetic neuropathy in detail. Okay. Now, what autonomic neuropathy leads to? First thing, we will lose the control on the heart rate and we end up with resting tachycardia. Normally, when do I get tachycardia? When my body needs increased heart rate. When my body needs increased heart rate, when I'm doing some physical activities, or when I'm scared, or when I'm stressed, or when I'm excited. But when I'm not scared, when I'm not excited, when I'm not doing any exercise, when I'm at rest, my heart rate is supposed to be in the normal range of 60 to 100 per minute. This is regulated by the balance between sympathetic and parasympathetic. Sympathetic wants to increase the heart rate, parasympathetic wants to decrease, and that balance gives me a heart rate of 60 to 100. Now, whenever nerves get damaged because of a systemic condition, it is the parasympathetic which are more vulnerable to damage than the sympathetic nervous system. There's a simple reason behind that. What is the reason? The sympathetic nervous system is not only dependent on the nerves, it has an endocrine organ as well. So adrenaline, noradrenaline can be produced from the adrenal gland as well. Sympathetic is purely a nervous system. Parasympathetic is purely a nervous system. So that's why when the neurons start getting damaged, even if the damage is equal to sympathetic and parasympathetic, sympathetic activity dominates because there is a gland also doing the same task. Parasympathetic is the one which suffers. So when I lose the parasympathetic, sympathetic overdrive, and I will have increase in the heart rate. So resting tachycardia. Okay. Second thing it can lead to is orthostatic hypotension. Orthostatic hypotension. That is when we suddenly stand up, your systolic BP dropping more than or equal to 20 millimeters of mercury, often giving the sensation of fainting or falling, right? Okay. The third thing it can lead to is diarrhea. Diarrhea, because even your peristalsis is under the control of the autonomic nervous system. So impairment can increase your bowel motility and cause diarrhea. So diabetic diarrhea, orthostatic hypotension, and resting tachycardia. These are the manifestations of autonomic neuropathy. And with this increasing resting heart rate, there is increased risk of dilated cardiomyopathy and thus the risk of death as well. Now, why should I get dilated cardiomyopathy with resting tachycardia? Is there any link? There are two mechanisms for dilated cardiomyopathy in diabetes mellitus. One of them is your blood vessels are getting blocked. That's what we discussed, ischemic heart disease. So blood flow to the myocardium is getting reduced. The second one, as the heart rate increases, its demand for the oxygen, blood supply and glucose increases. The demand may not be met because of the ischemic heart disease. The demand may not be met, resulting in thinning out of the myocardium and ending up with dilated cardiomyopathy, right? So these are all the microvascular complications: diabetic nephropathy, diabetic neuropathy, and then diabetic retinopathy. Diabetic So diabetic retinopathy is one of the leading causes for blindness world over. Cataract and diabetic retinopathy account for majority of the causes for blindness world over. So cataract is of course easily addressable or treatable, and diabetic retinopathy is one of the difficult to treat causes for blindness. So these are all microvascular complications. IHD, that is coronary artery disease, CVD or cerebrovascular disease, and PVD or peripheral vascular disease. These are macrovascular. All pathies, nephropathy, neuropathy and retinopathy, these are microvascular complications. Apart from these three, what other complications I can expect? Okay, so as we discussed, it can affect the GIT. Mechanism is mainly involvement of autonomic neuropathy, and it can result in diarrhea. It can result in diarrhea. Diabetic diarrhea is one of the difficult to treat causes for diarrhea. Now we have a lot of drugs which are helpful. We'll discuss that later. Okay, what genitourinary manifestations diabetes mellitus can cause? It can impair the urinary excretion from the bladder, so we will call it as uropathy. Even more important than that, particularly for the middle-aged or relatively young male patients, it can cause erectile dysfunction. How many of you are aware that presence of erectile dysfunction now is considered as a marker for the presence of ischemic heart disease in diabetics? It is considered as the marker for ischemic heart disease in diabetics. So whoever has erectile dysfunction and is having diabetes, indirectly we know that he has started developing the occlusion of the coronary arteries. It's a very, very important point. Okay. Then what dermatological manifestations diabetes can lead to? Of course, there is increased risk of wound infections, increased wound healing time. Yes, of course, there is increased risk of urinary tract infection as well, right? Increased UTI as well in diabetic patients, especially females. Apart from the delayed wound healing and increased risk of wound infections, it also leads to a complications called as necrobiosis lipoidica. Necrobiosis lipoidica. Now, what do I mean by this? So it's a chronic granulomatous inflammation of the skin, predominantly affecting the shin areas. Over the leg, over the shin areas, there will be formation of chronic granulomatous inflammation. Mechanisms include two things: microvascular occlusion and mainly the formation of transforming growth factor beta. This transforming growth factor beta stimulates excess deposition of the extracellular matrix, mainly abnormal forms of collagen. So that abnormal forms of collagen, inflammation because of the inflammatory cytokines, plus microvascular injury, all combined lead to these granulomatous ulcers in the shin area. We call it as necrobiosis lipoidica. Okay, so as you see here, you can see an inflammatory area with well demarcated erythematous edges. That's classical necrobiosis lipoidica. This is an image based question which has been repeatedly asked in the exams. Okay, now what musculoskeletal complications of diabetes we can expect? Okay, so diabetes leads to something called as cheroarthropathy. Cheroarthropathy. What do I mean by that? Basically, with diabetes, this increased expression of transforming growth factor beta, results in fibrosis of the skin around the joint, so makes the joints more stiff. Need not always be injury to the joints. The skin around and the soft tissues around the joint become more stiff because of fibrosis. Why the fibrosis is happening? Fibrosis is because of this transforming growth factor beta. And once the fibrosis happens, the joint mobility becomes reduced. So patients with diabetes often feel their joints are becoming stiff. One of the classical example, in fact, most common presentation is development of what we call as frozen shoulder, right? So that's what we call as cheroarthropathy, decreased joint mobility. This is because of fibrosis of the skin and soft tissues around the joint. One of the mechanism is transforming growth factor beta. Second, we developed something called as diabetic foot, which is extensive destruction of the joints and non-healing wound put together, increasing the risk of amputations, right? Okay, then diabetes is also associated with increased risk of developing the periodontitis or the gum infection and inflammation. And as we now recognize that gum inflammation is a risk factor for development of rheumatoid arthritis, and it's also a risk factor for the coronary artery disease and cardiovascular complications, including the endocarditis. So these are all other complications that diabetes can lead to, right? So to summarize, our diabetes, majority of the patients of type 2, when they present, they may not have any symptoms. Type 1 often present with symptoms. When they present with symptoms, mostly they are going to present with these polyuria, polyphagia, polydipsia, or a complication arising out of it like diabetic ketoacidosis or other acute complications. Type 2 may not present with the symptoms, and that's why screening the type 2 is very, very important. When should we start screening? We should start when someone turns 35 years. And if the screening is negative, he is not diabetic anymore, then every 3 years we need to continue screening. We may consider screening early, before 35 years of age, in individuals, especially Asians, with a BMI of more than or equal to 23, with an additional risk factor for diabetes, like having a family member with diabetes or hypertension, high triglyceride or low HDL, PCOS, or markers of insulin resistance. Okay, now if they are presenting with symptoms, these are the likely symptoms, and some of them may present at the stage when there are complications. The main mechanism for complication is oxidative stress because of formation of sorbitol, endothelin 1 overexpression causing vasoconstriction because of activation of the diacylglycerol protein kinase C pathway, and then formation of Amdori products resulting in advanced glycation end product which interact with its receptors, activating NFK beta pathway which stimulates production of inflammatory cytokines and growth factors, plus unutilized glucose contributes to accelerated atherosclerosis. All of them lead to tissue injury and blood vessel occlusion. blood vessel occlusion and tissue injury together leads to micro and macrovascular complications. IHD, that is coronary artery disease, CAD, CVD and PVD are macro. All pathies, nephropathy, neuropathy, retinopathy are microvascular. Most common cause for CKD world over is diabetic nephropathy. One of the common causes for the blindness world over is diabetic retinopathy, right? And diabetic neuropathy is the most common cause for polyneuropathy. The most common cause for polyneuropathy is diabetes mellitus itself. B12 deficiency, lead neuropathy, they're all relatively rare. Diabetes is the most common cause for polyneuropathy. Apart from this, diabetes can also lead to diarrhea, erectile dysfunction, and presence of erectile dysfunction. Erectile dysfunction is primarily because of the blood vessel occlusions. Erection itself is a result of vasodilatation. If blood vessels are already occluded, vasodilatation may not happen. Erectile dysfunction ensues. So if already erectile dysfunction is present in a diabetic, that means coronaries also have reasonable degree of occlusion. So it can be considered as a marker of presence of coronary artery disease in a patient with diabetes. Then cutaneous, it can lead to a granulomatous inflammation called as necrobiosis lipidica. It can lead to diabetic foot. In fact, it is one of the leading causes for the below knee amputations world over. And it can also lead to stiffening of the joints or reduced joint mobility because of skin and soft tissue fibrosis. One of them is what we call as frozen shoulder, right? And it can also cause gum inflammation. So these are all the clinical manifestations of diabetes. So in the next class, now that we know the diagnostic criteria and clinical manifestations, in the next class we will talk about the management. We will start with the pharmacology in one session, and then we will learn how to or when to start medications, what medication should be started. If non-responders, how do I escalate the dose? Or if complications happen like hypoglycemia, how do I decrease the dose? When to bring in insulin and when to bring the modern drugs. All of that we'll discuss in the next class. Today was about the clinical features, but before I sign off, we'll take a question about what we have learned today. Which of the following is false about pathogenesis of long-term complications in diabetes mellitus? Okay. Option A, activation of polyol pathway. Option B, inhibition of protein kinase C. Option C, upregulation of VEGF expression. Option D, upregulation of transforming growth factor beta. So what do you think is the right answer here? What they're asking? False, not involved in the pathogenesis of complications of DM. Let's see how many of you can answer it. Okay, so it appears most of you are going to give the right answer. So let's see how many of you answered it right. Okay, awesome. So all of you gave me the right answer. Yes. So there is, of course, activation of polyol pathway, sorbitol formation and oxidative stress. There is no inhibition of protein kinase C. There is actually activation of protein kinase C, which is contributing to increased expression of endothelin and basement membrane thickening. Yes, there is upregulation of VEGF, particularly this plays an important role in the diabetic retinopathy. And there is upregulation of transforming growth factor beta. It plays an important role in aging and fibrosis of various tissues. So all of these are seen and option B is not seen. So that becomes the answer for our question, right? Okay, so that's it for today. I'll see you in the next class. I will share the detailed schedule on the Telegram soon. And what I'm planning to do is that we will start also every month we'll have at least one case presentation. So if any of you want to volunteer to present a case, connect with me or the Medit team on the Telegram. So as part of the Reed Harrison series, we will complete a disease, we will have a case presentation, we will discuss the Vygotsky and the kind of questions that examiners ask you during your case presentation, and then we will move to the next disease. So this way we will complete our theory learning so that you can write your prof exams. We will go through all the PYQs and PYTs so that we can deal with MCQs as well, and we can also deal with the case presentation. So if anyone is interested and want to volunteer, please connect with me. We will make a list of cases. You don't have to bring the patient or anything. You can just present the case sheets and we will have a Vygotsky kind of interaction live. Okay. And if you are little concerned about showing your face, no need to worry. You can present without your face being visible. Okay. So that's it for me today. I'll see you in the next class. Till then, have a good time. Bye-bye. Thank you. Thank you, everyone. Thank you.